Today we'll be discussing about cardiomyopathies. So cardiomyopathies are the primary diseases of the myocardium. They can be inherited or can be caused by infections or the exposure to the toxins. In some cases, however, it is very difficult to find the cause. They are classified according to their effects on the cardiac structure and function. They are mostly due to the mutations seen in the sarcomeric genes encoding the thick and thin myofilament proteins. This is a drawing of a myocyte indicating multiple sites of abnormal gene products associated with the cardiomyopathies. Basically, the mutations occur in the dystrophin complex or in the desmosome complex or in the sarcomeric proteins. Cardiomyopathies can be classified based on the phenotype into the various types. Like they can be classified as hypertrophic cardiomyopathy with asymmetric septal hypertrophy, hypertrophic cardiomyopathy with concentric hypertrophy, similarly hypertrophic cardiomyopathy with apical hypertrophy, and similarly dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, obliterative cardiomyopathy, and restrictive cardiomyopathy. This is the classification which is based on the phenotype. Similarly, they can be classified based on the etiology. They can be either primary cardiomyopathy or the secondary cardiomyopathy. Secondary cardiomyopathies occur secondary to other systemic diseases, and the primary cardiomyopathies are mainly genetic or mixed genetic and acquired. Now, this box, which is taken from the Davidson's Principles and Practice of Medicine, shows the specific causes of the secondary cardiomyopathies, which include viral infections, bacterial infections, protozoal infections, similarly endocrine diseases like diabetes, acromegaly, and the connective tissues like systemic sclerosis, polyarteritis nodosa, infiltrative disorders like hemochromatosis, toxins like alcohol, and the neuromuscular disorders like dystrophia myotonica. So now, we'll discuss about the dilated cardiomyopathy, which is one of the very important cardiomyopathy, which is frequently seen in the many patients who present to the hospital. So dilated cardiomyopathy has the incidence of about 20. Similarly, prevalence is 38 cases per 100,000 population. Men are affected more often than women. And the pathogenesis is basically the dilation of the ventricles and the impaired contraction, leading to impaired functioning of the heart and the heart failure. In this condition, a left ventricle mass is increased, but the wall thickness can be normal or reduced. Specimen of the heart, which was removed at the dilatation, and the more that this dilated ventricle. This is the feature of the dilation of the ventricles. There is the dilation of the valve rings that leads to the functional MR and TR. Histologically, there will be the myofibrillary loss, interstitial fibrosis, and the T cell infiltrates. And one of the important causes for this cardiomyopathy is alcohol. In 25% of the cases, it can be autosomal dominant, and there are various, you can identify various single gene mutations like mutation in the dystrophin, laminin, ANC, emerin, and the metavinculin. In some cases, dilated cardiomyopathy is also associated with the other skeletal muscle abnormalities, which can be seen in the X-linked abnormalities of skeletal muscular dystrophies like Baker's and the Duchenne's muscular dystrophy. Similarly, some dilated cardiomyopathies may be secondary to the late autoimmune reaction to the viral myocarditis. Similarly, HIV can cause cardiomyopathy and dilated cardiomyopathy in 10% of the cases. Patient will usually present with the symptoms of the heart failure, and this condition may be found incidentally during the routine investigation. Patient can also present with arrhythmias, features of thromboembolism, and can present as a sudden death. However, this sporadic chest pain and exercise intolerance is a very frequent symptom. However, before diagnosing dilated cardiomyopathy, we should rule out coronary artery disease with the ventricular dysfunction first. For the diagnosis, echocardiography and the cardiac MRI play a pivotal role, and they are most useful investigation. You can see in this left ventricle right of the dilated cardiomyopathy in the echocardiography. ECG is usually non-specific, and genetic testing for the various mutations might be necessary if more than one family member is diagnosed with this condition. For the management, we usually manage the symptoms and we manage the heart failure. If the patient is not responding to the heart failure medical therapy, then they may require cardiac desynchronization therapy, and those patients who are at high risk of sudden death might require implantation of the cardiac defibrillator. Similarly, this risk of the sudden arrhythmias or death is high in this condition. So this can be prevented by using the beta blockers or either AC inhibitors or ARBs. Next important cardiomyopathy is hypertrophic cardiomyopathy. This is one of the most common form of cardiomyopathy. The prevalence is about 100 cases per 100,000 population. There is inappropriate and elaborate left ventricular hypertrophy with malalignment of the myocardial fibers and the myocardial fibrosis. As you can see in this picture of the patient with the hypertrophic cardiomyopathy, it shows the characteristic disarrayed myocardium myocyte architecture with the swelling and the branching rather than the usual parallel arrangement of the myocyte. This is a typical histological finding of the patient with hypertrophic cardiomyopathy. So hypertrophy in the cases of the hypertrophic cardiomyopathy can be either generalized, or it may be confined to the interventricular septum, or it can be apical. This is a picture which shows the various types of the hypertrophy which can be seen in hypertrophic cardiomyopathy. In the picture B, you can see that there is asymmetric septal hypertrophy with the systolic anterior motion of the mitral valve causing mitral reflux and the dynamic left ventricular outflow tract obstruction. Similarly, the picture C shows the concentric type of the hypertrophy, and the picture D shows the apical hypertrophy in cases of the hypertrophic cardiomyopathy. This is the gross specimen of a heart with the hypertrophic cardiomyopathy, which was removed at the time of transplantation, and it shows the asymmetrical hypertrophy of the septum, where the septum is into the left is systolic anterior moving towards the septum. This causes the dynamic outflow tract obstruction during exercise or the physical exertion. So this is a very important condition which can lead to sudden death in the young athletes due to sudden cardiac arrest secondary to arrhythmias. So pathogenesis is basically, it is a genetic disorder with autosomal transmission. It has high degree of penetrance, however, there is variable expression, and mostly there are single point mutations in the sarcomeric contractile proteins. If there is mutation in the beta-myosin heavy chain, then patients with elaborate ventricular, there will be the diffuse type of the ventricular hypertrophy. Whereas if there is troponin mutations, there may be little or no hypertrophy, but patient will have the high risk for the hypertension and the sudden death. Similarly, if there is mutations in the myosin binding protein C, then they will present in the later stage of the life, and they are associated with the hypertension and arrhythmias. However, in all subtypes of the hypertrophic cardiomyopathy, heart failure can be the end result due to the impaired diastolic filling of the stiff, non-compliant left ventricle. And as we have discussed, there may be the isolated septal hypertrophy. When there is a septal hypertrophy, asymmetric septal hypertrophy, it can cause a dynamic left ventricular outflow tract obstruction. And in this condition, there can also be associated systolic anterior motion of the mitral valve. So there can be the coexisting mitral regurgitation due to this anterior movement of the mitral valve during the systole. Patients will present with the effort-related symptoms, which these symptoms are almost similar to the presentation of the aortic stenosis. They will present with angina, breathlessness, arrhythmias, syncope, and the sudden death. However, we can differentiate this condition from the aortic stenosis by the presence of the jerky pulse, where the pulse in the aortic stenosis is slow rising and late peaking. This picture again summarizes the clinical features of the hypertrophic cardiomyopathy. We should note in this picture that the apex in cases of the hypertrophic cardiomyopathy may have the double impulse because of the palpable fourth heart sound due to the left atrial hypertrophy. Similarly, the murmur of the hypertrophic cardiomyopathy is a systolic murmur heard at the base, and this murmur typically is augmented by standing due to the reduced venous return and by the ionotropes and the vasodilators like sublingual nitrate. So these maneuvers can help us to differentiate the murmur of aortic stenosis and the hypertrophic cardiomyopathy. And one of the important clinical features of this condition is sudden death. It is one of the most common causes of sudden death in young athletes, and it typically occurs during or just after the vigorous physical activity, and mostly the deaths are due to ventricular arrhythmias. The risk of the sudden death is higher in those patients with a history of previous cardiac arrest, or the previous history of sustained ventricular tachycardia, recurrent syncope, or those with the adverse genotype or the family history, and those with the exercise-induced hypotension. Similarly, in the patients who, or the athletes who had a history of the non-sustained ventricular tachycardia and ambulatory ECG monitoring also have the high chances of the sudden death. And similarly, the marked increase in the left ventricular wall thickness more than 30 mm during echocardiography can also lead to the sudden cardiac death. So these patients with high risk of the sudden cardiac death or sudden death might require ICD insertion to prevent this sudden death. For the diagnosis of the hypertrophic cardiomyopathy, echocardiography is the investigation of the choice. It is usually diagnostic. It will show the echocardiogram of a hypertrophic cardiomyopathy. Systolic anterior motion of the mitral, anterior systolic anterior movement of the mitral valve. So this causes the dynamic outflow obstruction. This is the typical diagnostic feature which can be seen in the echocardiograph. echocardiogram of a patient with hypertrophic cardiomyopathy. ECG may also show the features of LVH and deep T-wave inversions. However, these findings are non-specific. And in some cases, we might need to perform the cardiac MRI to confirm the diagnosis. And the genetic screening is reserved for the relatives of the affected individuals. So for the management, basically we manage the symptoms, and for the symptomatic relief, patient can be prescribed beta blockers, as well as we can use the rate-limiting calcium channel antagonists like verapamil and the antiarrhythmic drug like disopyramide because of their negative ionotropic effect. If the patient presents with arrhythmias, they can respond to amiodarone or the disopyramide. Similarly, if there is outflow tract obstruction and if the medical treatment is not possible, then the surgical resection of the septum can be done, which is known as myectomy. And similarly, if the patient is not willing to undergo the surgery, septal ablation using the catheter-delivered alcohol solution can be done. However, you should understand that there are no any pharmacological therapy that can improve the prognosis. It will just improve the symptoms of the patient. And as I mentioned, some patient with a high risk for the sudden death will require the ICD insertion. However, we should avoid the use of digoxin and the vasodilators because this increase the outflow tract obstruction and can increase the symptoms and then can increase the chances of the sudden death. Although rare, this arrhythmogenic ventricular cardiomyopathy is a frequently tested topic in the various MCQs. So you should know something about this too. It predominantly affects the right ventricle. However, if there is involvement of the left ventricle, prognosis is usually very bad. It is autosomal dominant condition with a prevalence rate of about 10 cases per 100,000 population. And the genetic defect is basically present in the desmosomal protein genes. Basically, the most common mutation is seen in the lactophilin 2, that is PKP2. In this condition, there is replacement of the patches of the right ventricle myocardium with the fibers and the fatty tissues. As you can see in this picture, this is the cross-section slide of a pathologist specimen and the thinning of the right ventricle tissue and the fibrous tissue. And in this picture, by transillumination. So in this condition, basically the pathology is mostly confined to the right ventricle. However, if left ventricle is also affected, the prognosis is not good. Clinical features, basically patient will present with the feature of the right-sided cardiac failure like raised JVP, abdominal discomfort, ascites, liver enlargement, and swelling of the limbs. Patient can also present with the various ventricular arrhythmias, and they can also have sudden death. So for the diagnosis, we use the various set of the criteria that take account of the ECG, structural assessment, genetics, and arrhythmias. ECG will show the brightly wide complex QRS complex and the inverted T waves in the right precordial leads. However, these are non-specific findings, and MRI is also helpful for the diagnosis, and it is also useful for screening first-degree relatives of the affected individuals. For the treatment, we have to treat the right heart failure with diuretics. Cardiac arrhythmias should be treated with the beta blockers or the ICD insertion for the patients who have risk of the sudden death. Next important cardiomyopathy is restrictive cardiomyopathy. In this condition, ventricular filling is impaired because ventricles are stiff and they are unable to relax properly. This restrictive cardiomyopathy can be familiar, and it is usually associated with the other restrictive diseases like hemochromatosis, sarcoidosis, amyloidosis. In this condition, when the ventricles are stiff, this leads to the very high atrial pressure with atrial hypertrophy, dilatation, and when the atria starts to dilate, there can be atrial fibrillation. You can also see in this picture dilated. So this is a typical picture of the restrictive cardiomyopathy. The causes include the amyloidosis, which is the most common cause. Similarly, other storage diseases like glycogen storage disease and other diseases like idiopathic perimyocyte fibrosis and familial forms are the causes for this condition. The clinical features include the exercise intolerance, congestive symptoms of the heart failure, and relatively they can present with the more right-sided symptoms like edema, abdominal discomfort, and ascites. And then you can see because of when atria contracts against the stiff left ventricle, there can be the presence of the fourth heart sound, and in the JVP there can be the rapid Y descent, and the JVP increases during the inspiration. Diagnosis is based made on the echocardiography, as well as some cases we might need to perform CT or MRI, and in some confusing cases, endomyocardial biopsy can be done to look for any infiltrations or to look for any typical histology suggestive of the restrictive cardiomyopathy. As you can see in this picture, there is a direct atrium. However, the left ventricle and the right ventricular chamber are of the normal size. This is a typical feature of the restrictive cardiomyopathy. Treatment is basically symptomatic, and in some cases who are symptomatic, even after the medical therapy, they might require cardiac transplantation. So one of the rare form of the cardiomyopathy is obliterative cardiomyopathy. The unique feature of this cardiomyopathy is that it involves the endocardium. There is a involvement of the endocardium of the one or both ventricles, and when the endocardium is involved, there can be the thrombosis and fibrosis leading to the obliteration of the ventricular cavities by the fibrous tissue, the pulmonary embolization, heart failure, and the mitral and the tricuspid regurgitation. These are usually associated with eosinophilia and can occur in the eosinophilic leukemia or the eosinophilic granulomatosis with polyangiitis. Mortality is very high. Treatment basically is the simplified therapies, diuretics, and the surgery might be necessary if in which we do the decortication of the endocardium and the mitral and the tricuspid valve replacement. So one of the frequently asked MCQ is about the Takotsubo cardiomyopathy or the Takotsubo syndrome. It is also known as apical ballooning syndrome or the stress-induced cardiomyopathy. It is also a form of the acute left ventricular dysfunction, which is characterized by the dilation of the left ventricular apex and the adjacent myocardium, whereas narrowing of the base of the heart. So that will lead to the typical morphological feature suggestive of the, which is similar to the Takotsubo. The mechanism is basically the noradrenergic coronary vasoconstriction and the acute left ventricular outflow obstruction. It is basically associated with acute environmental or the emotional stress, and the clinical features include the chest pain, breathlessness, and the cardiac failure. And it is more common in women than in men, and ECG and the symptoms can mimic the acute ST elevation MI. So we should be very careful while diagnosing this condition. The diagnosis is basically made during the coronary angiogram. When we suspect MI and subject the patient to the coronary angiogram, when the coronaries are found to be normal or involved only minimally, then we have to suspect the Takotsubo cardiomyopathy in the background of the relevant history. In the echocardiography, we can see the apical ballooning of the left ventricle. The apex will be dilated, whereas the outflow tract will be narrow. So that will resemble a Japanese octopus trap, which is also known as Takotsubo. So this is how the name was derived. The treatment is basically treatment of the left ventricular dysfunction, and this the LV dysfunction usually recovers within 4 to 5 days without further treatment. And we can use the beta blockers to prevent the arrhythmias, AC inhibitors to treat the LV dysfunction, and these drugs can be continued until the cardiac function has recovered, and then we can stop the drug. So thank you very much